Welcome to Future Conversations, the podcast that explores research through the lens of tomorrow by Monash University, Malaysia.
Welcome to the podcast, rooted in research, shaping the future through conversations today. The pace of scientific discovery today is staggering. We can now edit genes, implant electrodes in the brain, and let artificial intelligence assist doctors to make diagnoses, all things that once belonged to science fiction. But as science races forward, ethics often struggles to keep up. How do we decide what's right when technology can change the very nature of being human? Who gets access to these medical breakthroughs and who gets left behind? And how do we protect autonomy, privacy, and dignity when innovation moves faster than regulation? We are discussing the topic of bioethics today with John Gardner, Director of the Monash Bioethics Centre, Monash University, Australia, Dr. Mark Tan, Associate Professor, Medical Ethics at the Jeffrey Cheah School of Medicine, Monash University, Malaysia, Mark Cheong, Deputy Head of School Education, School of Pharmacy, Monash University, Malaysia, and Adrian Carter, who leads the Neuroscience and Society Group at Monash Bioethics Centre, School of Philosophical, Historical and Indigenous Studies, and an Adjunct Fellow of the School of Psychological Sciences, Monash University, Australia. Welcome to the show, gentlemen. How are you today?
Very well.
Very well, thank you.
I'm going to start with John. John, you are a sociologist, and I understand the Bioethics Centre sits in the School of Arts in Monash University, Australia. I was rather surprised. Why? Why does it sit in the School of Arts?
Yeah, it is unusual. You'll find that a lot of bioethics centres sit within medical schools and in some cases within law faculties. But a major dimension of bioethics is philosophy and moral philosophy. And that has conventionally been the strength in bioethics at Monash, and hence its situation in the Faculty of Arts, where, of course, philosophy is based.
Yeah.
So it was established in 1980 by Peter Singer and Helga Kusei. And, of course, they're both philosophers. So from the very beginning, it was entrenched in the Faculty of Arts.
Okay, and you're a sociologist.
I'm a sociologist, yeah.
What got you interested in bioethics?
Well, as a sociologist, I'm interested in how social values, social norms shape our infrastructures, our technologies. And of course, medicine is a technology-rich or infrastructure-rich practice. You know, medicine is done through technologies and within infrastructure. And inevitably, that infrastructure reflects social values, even if we might not necessarily think of the infrastructure in those terms, but it does. It reflects social values, social norms. So that's the sort of thing we're interested in sociology.
Yes.
And there's, I guess, a natural link there with bioethics, which is exploring how those infrastructures shape and constrain behaviours in research and clinical settings. So how might an infrastructure support practitioners, doctors, nurses to behave in ways that we consider ethical, or how might it constrain or prevent them from behaving in ways that we think are ethically appropriate?
Yeah, which is what I always say with the whole hype about technology and AI and all of that. People are just forgetting the human side of what this means to them and how do we manage that, right? So we've got four of you of different disciplines. Mark Tan, who's a clinician, a doctor by profession. We've got you, John, a sociologist, Adrian, who's a neuroscientist, and Mark Cheong, who's actually from the area of pharmacy. So how would you define bioethics in your field, Mark Cheong? I'm going to refer to Mark Tan and Mark Cheong because you both have the same name.
Thank you very much, Mira. I think in pharmacy, ethics is primarily for us the concern around who gets what medicines, and how do we ensure that medicines which are out there are used safely, not only for individual patients but also for the public as well. My own interest in ethics within the area of pharmacy largely came from my own personal experiences working within our public healthcare system, where as a young pharmacist you very quickly encounter the problem of inadequate resources, insufficient supply of medicines, as well as the very slow adoption of new medicines and new cures for reasons that are largely monetary in nature, because they are too expensive. So even though you can have life-saving cures out there, they don't get to the people who need them simply because either the system doesn't have the resources to support it, or people are just too poor to pay it out of pocket, which starts to raise all sorts of interesting questions about whether is this right. Should how much money you make really determine whether or not you get access to a life-saving cure? And I think even as pharmacists working within health systems, you very quickly encounter difficult questions around, if you have two competing patients who are similarly ill, but you only have one quota of a particular life-saving drug, who do you give it to? How do you make these difficult decisions? And so all of these become ethical questions to us. And many of us pharmacists also work in the private healthcare sector, community pharmacies, retail pharmacies, private hospitals, where the question of commercial interests come into play as well, where most of us in these fields make our living selling medicines. And then now comes the question of how do you deal with these competing commercial and financial interests while still striving to live up to the primacy of patient interests that our profession tells us to do. So ethics in pharmacy largely revolves around these questions.
And many layers to it, isn't it?
Yes, absolutely.
Pharma companies, community pharmacists,
Correct.
in some cases doctors, even in Malaysia. So where does it stop?
Correct.
Right? Yeah. What about you, Adrian, from a neuroscientist perspective?
Yeah, I guess I think around bioethics as the use of science and medical research in a way that's consistent with our values. So respect for the dignity of all humans, and trying to allow people to live the life that they want to live, and also doing that for other people. So there's the values of community and solidarity. I work within a subdiscipline of bioethics called neuroethics, which focuses on how neuroscience research might change the way that we think about ourselves, our ability to control our own behaviors and thoughts and cognitions, and the way that we might use technologies to try and improve our well-being and to fulfill our potential, as well as to treat intractable medical conditions or mental health issues.
Yeah. And it's interesting that you also do a lot of work around addiction neuroethics.
That's
in
correct.
particular. Yeah, we'll have a lot to talk to you about when it comes to bioethics. What about you, John?
Yeah, so as a sociologist, I'm very interested in the systems that can support good ethical conduct in clinical and research settings. Obviously, we want our practitioners as individuals to have good moral judgment, but we have to understand that the realities of day-to-day research, or especially clinical care, is that there's a lot of resource constraints. People are often overworked. We can't always rely on the moral judgment of the individual. You want a system around them to support good ethical conduct, good ethical behavior. So that's really where my interest sits within bioethics. It's about those supporting systems, those processes, those cultures of good ethical behavior, but thinking about culture not just in terms of norms, but sort of supporting infrastructure.
So you would keep these guys in check, really?
Well, not me personally. I would work with them to create a system that can keep them in check.
Absolutely.
Yeah.
Mark Tan?
So I think bioethics in itself is just really wide and really interdisciplinary. From a medical perspective, and I hesitate to even say medical ethics, because it really should be kind of like healthcare ethics, because it just transcends all the different aspects of healthcare. Personally, I work in clinical ethics, which deals with the ethical issues that arise in clinical care. So and the focus is really on the patient and the doctor, and sometimes that kind of also contradicts a little bit with people who work in public health ethics, where the focus is really on the benefit for the population. My interest really, like Mark, stems into or dwells into end-of-life ethics, really. And that came from my experiences working in a big, large tertiary hospital, as well as a small rural district hospital in Malaysia, and the various ethical issues and some personal moral distress that I encountered, not knowing where I could get help back then. And I think over the years, what makes clinical ethics and bioethics really interesting is that the solutions need to be kind of contextualized to a particular setting. So although we have guiding principles that may guide all of us in our areas of ethics, but with clinical ethics, for example, a similar case that occurs in, say, Kuala Lumpur and a similar case that happens in Sabah may have different sorts of resolutions just because of the context in which it happens.
Yeah. So hence the contextualization. Adrian, you work in the ethics of neurosciences, in neurointerventions, I apologize, from deep brain stimulation for Parkinson's patients, which is implanting electrodes in the brain, to cognitive enhancement devices and all of that. Is there a code of conduct for neuroscientists as to where the boundaries are? And if you could also talk about contextualizing that, how would that look like in terms of code of conduct?
Yeah, so I guess all the codes of conduct stem from the Declaration of Helsinki and a number of other reports that came out of the product of, I guess, the atrocities from World War II, and it sort of set the minimum standards for ethical research and clinical practice. And so they are then informing a whole range of codes of conduct that govern professionals. So with clinical practice, there'll be within each country, they'll have a professional code of conduct that clinicians have to adhere to, and that's part of their registration. And if they violate those codes, then that might affect their registration, might be suspended or terminated. Within research, there's most countries will have some sort of national statement to guide the ethical research, and that then informs the ethical review board. So if you're wanting to do research within a university or a hospital, you then have to apply to an ethical review board to get approval for your research. And if you conduct your research in a way that is deemed unethical or inappropriate, you might then be reprimanded with research misconduct. So they're the kind of ways in which the behaviour of clinicians and researchers are constrained.
Everyone's idea of boundaries is different. So you may have codes of conduct, but is that enough? Or, we can't be adding to these codes of conduct. It's useful. Even you talk about regulation, how much regulation do we need? Is it ever going to be enough? So what's a sustainable place to be at so that we can all go ahead and do the research, practice, do all of that, but yet have this moral obligation at the back of my mind? The reason I ask you is because you are in your area of interest, we're always dealing with people who are vulnerable, people who are desperate for a cure or something that can enhance or make their lives better. So you have that dilemma. Maybe John can add to this conversation.
Yeah, look, I think this speaks to the importance of having multiple mechanisms, for lack of a better word, for supporting good ethical conduct behaviour, codes of practice being one mechanism. I think in any research or clinical service setting, I think the ideal is to create a space where there's some open reflection on ethical issues that are arising in context, where people can sort of say, look, I'm feeling this way because of the situation that I was in, perhaps someone expressing moral distress, and perhaps there might be a clinical ethicist on hand, or it might just be other colleagues who have gone through something similar. They can have an open discussion about, well, look, here are some ways forwards. Here is how I managed that tension. This is what the consequence of that was. And also to I think, be open when for people to be open about the fact that actually they can't see any clear way forward about managing a particular tension, and to think, okay, well, is there somewhere that we can elevate this to? Is there, another, what we might call moral authority that's appropriate here? It might be a clinical ethics committee, or it might be a religious figure, depending on the context. So I think if you can create that awareness that ethics is not just about a tick box exercise, but is something that we are constantly learning how to manage, and that it's sort of a muscle that you exercise, that you should be reflective, communicate openly with your colleagues, embrace the fact you're not always going to get it right, and be compassionate with your colleagues and realize they're not always going to get it right either.
Yeah.
I think that's the sort of thing that you would want to foster, so that would help contextualize any codes of conduct that there are.
Yeah. Mark Tan, sorry. Did anybody want to add?
I was just going to add that I think these codes of practice, they ensure that we avoid the I guess the most serious violations of people's autonomy and freedom. But beyond that, we then need to create a culture that enforces values and competencies within professionals. So how to deal with vulnerable people, how to manage complex situations between families, and those things are about the qualities of being a great clinician.
Yeah.
But they don't tend to be codified within the ethical codes of conduct.
So I think So I think for me, because every human being is different, the brain is so complex. It can alter people's behavior to a certain extent, and it might alter my behavior, it might not alter your behavior. So what do we do then? Because if it alters my behavior, I'm not myself anymore.
Yeah.
My decision-making process is different.
Yeah.
So where do you, hence I'm trying to make sense of where bioethics would apply to a situation like that.
I guess that's where a robust informed consent process is. So if in the area that I work in with Parkinson's disease, people will either have deep brain stimulation or take a medication to replace the dopamine activity that they've lost. And for some people, they can induce very significant changes in personality. They can lead to impulsivity and mania, compulsions and addictions, but it's only a minority, but it's a significant minority, about 1 in 5. And so understanding that and communicating that clearly to patients before they agree to consent to a new treatment is critical. Part of that is understanding the ability for someone who's in that situation to really comprehend that information. So if you've just been diagnosed with Parkinson's disease, which is a largely intractable condition that will ultimately degenerate and get worse, your ability to really take in that nuanced information is really difficult. So I think that's where clinicians have to have a really nuanced understanding of how they're communicating, make sure that, checking to make sure that people understand, talking to their families as well, because it doesn't just affect the individual, it affects their carers, their loved ones, who then might have to deal with those behaviours. So I think that's critical in those situations, but also without alarming people, because 4/5 of the people who take those treatments won't have those sort of behaviours, so you don't want to unnecessarily worry people. So that it is a really finely balanced discussion.
Fine balance, fine balance for sure. Anybody want to add on? No?
Well, I'd say, while you, for example, Adrian's example of deep brain stimulation and Parkinson's, as medicine progresses, there'll also be, experiments and new uses, for example, and that's another area that is really interesting and creates complex ethical issues, and these sorts of things will continue to happen because in science we are continuously progressing, and every time there is progress in science, simultaneously there are ethical issues that need to be addressed. And for example, it's still a bit controversial, I guess, with deep brain stimulation in Parkinson's, but it's probably better studied. But there will be uses for deep brain stimulation in other sort of neurological kind of conditions in future, and I think there are people who are already doing that, and then there are nuances that need to be put in. So that's where you might think about having little codes of conduct, or even just little safeguards about discussing with ethicists or ethics committees to just make sure that we're doing things properly in an ethical manner and doesn't cause alarm, I guess. And
Yeah. Because I was just reading recently about a medical device that was used for heart condition. I'm not going to mention company names, and where they knew that it was causing adverse reactions to the patients, but they didn't stop. And then the argument was it's a win-win for the patient, for the doctor, for the medical device company. So hence that, like, when do you stop? And this was commercialized. And sometimes medical devices are not as stringently monitored or controlled compared to pharmaceutical products, for an example. So it just got me thinking about this whole idea of bioethics and when do you stop. Mark Cheong, from a pharmacy perspective, accessibility, you spoke about that just now in terms of medical innovation. How do we bring about greater equity and perhaps even evidence-based practices to the pharmaceutical sector?
Yeah. So I think it starts off with perhaps a recognition that the current system that we have for encouraging and rewarding innovation is one that is very much profit first, and as such is, well, for lack of a better term, broken. Right. What we currently have now, especially in the area of pharmaceuticals, is this system whereby you incentivize and you promote innovation, which is great. We rely on innovation for development of new medicines and new cures, but it's a system whereby you then reward that by allowing pharmaceutical companies to then apply for patents, which can last decades, which then effectively provide them with a monopoly, which allows them to set very high prices. And all of this is underpinned by the idea that innovation and R&D in pharmaceuticals is risky, it's expensive, so you have to make these kinds of concessions to the innovators in the pharmaceutical companies in order to incentivize this. But what then happens, as I've alluded to previously, is that it means that many of these innovations come into the market with exceedingly high prices, which means that only the very rich can get access to it, and then the poor are left behind. And which raises the question then, does your degree of wealth change your degree of needs, right? And obviously we know morally it doesn't. And so really the question is how do we break this? And there have been multiple ideas that are floated. I think the first is to really look for ways whereby we can de-link innovation from all these intellectual property and patent regimes that essentially award monopolies to companies. So by delinking, you're essentially taking the cost and the risk of R&D out away from the final price of the drug that is set. What's been proposed is that we reward companies through prizes or through one-off payments, which will then sufficiently compensate them for many of the risks and investments that they have made, while ultimately driving down the final cost of the drugs that go out into the public much lower to make it much more accessible. So that's one way we start to look at it. And once we do have these affordable, or these innovations are being made affordable to the public, then we then encounter the next area, which is really looking at with healthcare systems having limited resources, how do we tackle the question of dividing these resources among the people? And so what's commonly used often in the pharmaceutical or pharmacoeconomics field is something called cost effectiveness, right? You want to get the most bang for your buck, per se. We also have to recognize that simply relying on the efficiency in how you divide your limited resources is also ethically problematic, right? You don't want to simply look at what gives you the most bang for your buck, because sometimes it means that you will have a smaller group of people, let's say with certain neglected diseases or rare diseases, which then get excluded because their costs of treatment for each individual patient are far greater than, let's say, someone with diabetes, right? And likewise, you don't want a situation where you only fund treatments that that address the largest group in the room, even though it only makes a modest improvement in their life, while foregoing, let's say, very innovative, very high-tech, life-saving treatments for a small group of people. So these are some of the balances that we have to contend with within the area of pharmaceuticals in order to ensure that while we do promote and provide for medical innovation, and governments certainly everywhere are very interested in that, these moves or measures to promote medical innovation must ultimately be constrained by questions of how do you ensure that the final products are accessible equitably, they benefit most people, and that you don't actually create discrimination or exclude groups of people from these innovations.
Who should lead this conversation? We've been talking about this for years, Mark. I don't see light at the end of the tunnel. It's such a complex industry with just involving governments as well and pricing, isn't it? It's not just pharma companies. One-off payment, Mark, I don't think anyone is going to buy that. Not in my lifetime. And it is a big problem. It is a big problem, especially now that we have medical inflation and we've got all of these, prices and logistics issues and supply chain issues and all of that. So prices are not going to come down. Who leads this conversation?
I think rather than who leads this conversation, it's useful to look at who's been left out of the conversation traditionally. And for most of history, the public has been left out of this conversation, right? You have policymakers, you have clinicians and researchers, the pharmaceutical companies, corporate interests that have been leading this conversation for the longest time, with the public mainly being treated as the passive recipient for it. And I think increasingly as we engage meaningfully with the public through democratic processes, promoting greater transparency in how these policy decisions are being made, incorporating what each community or each society thinks is contextually right for them, and then having the public put forward their say into governments who then in turn make policies that regulate the commercial interests, there may be light at the end of the tunnel. So it's really, I guess, ensuring that every voice is heard in an open and transparent manner. And even putting aside regulation, this pressure from the public can result in us having norms, which you may not have legal mechanisms in place, but if we start to have norms that allow us to call out behavior that is egregious, call out profit making that is ridiculous, right? And then actually through that get governments to apply measures and pressures onto some of these more wayward actors, we may actually start to see more progress in this direction.
John, I need your input here. How do we get the public involved? These companies are huge. They're huge. They're giants compared to...
and there's a lot of public distrust around some of those companies.
Yes.
And certainly what we're seeing over the last 5 years is in the global north that there's a real sense of increasing distrust in government as well, and in processes and institutions. So creating a context for the sorts of discussions that are necessary, I think, is becoming more difficult when we look at countries like the US and, the UK. I don't know about Australia, but there's just so much distrust around authorities, around expertise. And look, there's always been this ongoing tension between how do we make the process more democratic by bringing in more voices, and then how do we also make sure that the process still works? And again, what we've seen in the US is that a whole lot of mechanisms that were put in place to bring in those voices have, after a few decades, become mechanisms that are gumming up the system. Yes. So outside the healthcare system, if we look at examples from outside the healthcare system, it's extremely difficult to build houses in some states in the US, and that's because of a whole lot of mechanisms that were put in place to make sure that communities had a say about what was built around them. So these are the other sorts of things that we have to consider. It's like, if we create these processes, how do we make sure that they genuinely bring in vulnerable and marginal voices, and what constitutes a vulnerable and marginal voice can change. So communities that were vulnerable or marginalized in some regards in the 60s and 70s are now sort of upper middle class communities that are very politically strategic in using some of those processes to prevent, again, the building of homes in their area. So all these things are, there's no easy solutions here.
No.
I think community organisations, when they come together, can be powerful advocates for policy change. We know, certainly in Australia, there's examples of the groups who got behind changes in policy for medical cannabis, and it was based on the evidence that showed that it was effective for children, very young children with very severe epilepsy, and governments can be very sensitive to that kind of political advocacy because they know that it's something that shifts public sentiment.
Yeah, you can lose elections.
Yeah, absolutely. And we also saw this in the use of psychedelics in Australia. So concerns about the rising suicide rates amongst veterans through post-traumatic stress disorder was a big motivator for the change in government policy that made those medicines available to those who were affected. So it can have changed. Whether you think that medical cannabis or psychedelics are a good policy decision isn't a thing, but that it shows the power of communities to advocate for policy change.
Yeah, I think with communities, I feel like when you hit a crisis, that's when the groundswell happens. But until you reach that crisis, everybody's sort of, and unless it affects you personally, people don't really see or feel the pain that some of these systems bring about. Mark Tan, do you want to add on to that? No? I'll come to you in terms of medical or telemedicine, for an example. So you sit in the Malaysian Medical Council, which is the regulator for the doctors in this country. Am I correct?
Yeah, so just a point of clarification. So I sit on the ethics committee of the Malaysian Medical Council. The Medical Council per se has members, council members who are elected, but I sit on the ethics committee, which is kind of one of the mechanisms there. Yeah, and I think one of the roles of the Medical Council is to issue guidelines, and one of them has been the ethical use of telemedicine in the Malaysian setting by medical doctors. Yeah.
So then, as I said, the codes of practice is there, the regulations are there. How do you train the practitioners to ethically use this? Yeah,
no, I think that's a really good question, and the question that I think we always grapple with as clinicians is, I can do this, but really, should I do it, right? Because I have the ability to do many things in medicine, but is this appropriate? And while we have guidelines, it's more important to train people to understand why they are doing what they are doing. And hopefully, if people read the guidelines and understand that, then it kind of changes their behavior. And not just merely following guidelines because they are there, right? And I think that's the part about educating people about ethics and changing behavior. But I guess as a precursor to that, the guidelines help people to understand. And so, for example, one of the things that we have mentioned in the guidelines is that the virtual consultation is no different from a physical consultation. Hence, the standards of care should be the same, right? So if you're going to take a history, perform a physical examination to come to a diagnosis, the same standards would apply if you are conducting a virtual consultation. Now, you may find limitations there because you're online and you can't do a physical examination. So the next question is then, what should I do, right? So if I'm confident enough to make a diagnosis because it's a simple diagnosis, that's fine. But if there is a need for a physical examination that requires the doctor to touch the patient, then the advice should be you'd probably have to come into the clinic or come to the hospital for us to get further evaluation done. And that's the kind of messaging that we're trying to send out, because there is a real lure towards taking or doing things in a kind of seemingly easier fashion. So online consultations will provide that sort of ease. It's faster, more efficient, quicker, less cumbersome for the patient. But we need to make sure that those kind of safeguards are there before doctors in Malaysia, for example, embark on this journey. Another example would be things like data protection and confidentiality, right? So again, a virtual consultation should have the same ethical standards of confidentiality as an in-person consultation. But what does that mean? Because if I'm online with someone else, as a doctor, I wouldn't ask the patient to pan around the room to see who else is in the room, right? And
Okay.
so you could see someone there, but you don't know if there's someone else in the room. And similarly, the patient won't know if there's anyone else next to the doctor. So the guidelines are there to, guide people as to the kind of ethical requirements, that the standards are the same, but then, it's understanding it and why we've put that there that is more important.
That's telemedicine.
Mhm.
I'm going to come to organ transplantation,
Right.
which is in Malaysia, the demand, is far outweighs the supply. And we have an opt-in system when it
That's
comes
right.
to organ transplantation, as opposed to Singapore, which has an opt-out sort of policy. So what are some of the ethical issues that we encounter here in Malaysia, and how do we overcome some of them, given that we have so few people donating organs compared to the supply?
Yeah, that's another really good question, and I think it's a whole systemic issue, and the issue of organ transplantation is not just with regards to the ethics, but also with regards to the medical side of things, as well as the law. So, unfortunately, in Malaysia, our law relating to organ transplantation, at least for cadaveric organ transplantation, is the Human Tissue Act. And that's a 1974 law that has never been amended. So that's been 50 years. So one of the easier ways or more straightforward ways would be to say, let's change the law. The question is, what should we change it to? And coming back to my question, just because we can change the law, should we change the law? And the reality is that, and this is a fun fact, in Malaysia right now, the rates of organ transplantation or the organ donation from non-pledges are higher than those who have actually pledged. And so the question is why? And I guess, we think of it as communication because of the opt-in system, you can pledge your organ, but when you're in that condition where you're brain dead and you become qualified to be a donor, your immediate next of kin will need to consent to that organ transplantation. Now, if you signed up and you've never told anyone that you were to be an organ donor, that becomes a problem because many times these sorts of situations come about quite suddenly. People are very emotional. They're in a shock that you're suddenly taken into this condition. And can you imagine a doctor coming up to say, would you like to donate your brother or your son's organs, right? So communication is more important. So just because we can change the law, will that really help? And so a lot of the efforts in Malaysia has been on creating awareness, increasing pledges, but more importantly, having that conversation with your loved ones about your wishes. Because even without that pledge, your loved one can still sign on to consent to the organ donation.
Yeah.
And I guess then the next question is then, if we do all of that, do we really need to follow in the footsteps of Singapore into an opt-out system, right?
Yeah. And communication, as you said, is absolutely key. But when we have more demand than supply, then who decides who gets an organ? I know we have a wait list, but that wait list is open to abuse as well. So how do we decide that in Malaysia?
Yeah, that's another very loaded question, I think. So in Malaysia, we have what we call the National Transplant Resource Center that helps to coordinate transplants. Unfortunately, in Malaysia, the waiting list for each organ is not centralized like in the States where there's UNOS. It's kept by the specific field, and some fields have a shorter waiting list and others have a longer waiting list. Kidneys are obviously one of the longest. In medicine, we say that we can start you on hemodialysis, and that's meant to be kind of a stopgap measure while waiting for a kidney transplant. But in Malaysia, the waiting time exceeds 10 years, and most people will be on dialysis till the end of life as the measure as opposed to an organ. So there's been talk about trying to unify all of that into a central organization, and such as the NTRC. There's also talk about then establishing what we call a transplant ethics committee to look at different situations that may arise, because while you have policies and guidelines, it won't be able to cover every different permutation that happens. And the other kind of transplant that we've not kind of touched yet is living organ transplant, where you can get a donor from someone who's living for paired organs like kidneys. So the question is then, who can donate? And there may be different kind of situations that may not be covered by guidelines and regulations and policies. So right now, the answer is no, right? Because we don't have a policy for that. But if we have a transplant ethics committee, we could deliberate on certain kind of scenarios. And I guess, for example, we have people who may have it's straightforward when you have a first degree relative who wants to donate. But what happens when it's someone non-related? We also have had cases where we have had non-nationals who want to come into Malaysia and perform their transplants in Malaysia.
That's a slippery slope.
From a donor,
Yeah.
and it could be a first degree, second degree relative, but they're both non-Malaysians, and they just want to use the healthcare system here because it's cheaper. But again, our current policies don't allow that. So by having these committees that can deliberate on a certain case on a case-by-case basis, that might help also to increase, organ donation, which is done in an ethical manner.
Yeah. But then again, there's always abuse, right? Room for abuse. We've seen it happening in the world where people are taken advantage of for their organs. So it needs to be tightly managed. Yeah.
Yeah. So I guess that's the other role, right? To make sure that the selection process is rigorous, to then interview these potential donors, and then to make a decision.
Is there directed donation, Mark?
Sorry?
Is there directed donation in Malaysia?
Not for cadaveric, but for living, obviously,
Of course,
you can do that.
Yeah.
Australia perspective?
So certainly not my area of expertise,
Okay.
but just to say, I think there has been a little bit of discussion around directed donation. I know one of my students looked into directed donation as a possibility, and this is a student who works in intensive care and had encountered people from Indigenous backgrounds who were adamant that their organs should go to people also from Indigenous backgrounds. And there's a very good justification for that, because there's a very severe clinical need within a lot of Indigenous communities for organs. So the diversity in Malaysia, in terms of religion, ethnicity, and so on, whether this idea of directed donation has come up, whether it's an issue or whether it would just be seen as something that it would destroy social cohesion if people could direct where their organs would go.
Yeah, so I personally, I haven't encountered any cases where there have been requests for directed donation, or if there was, the organ transplant team and the donation team would have counseled them that that would not be possible. And I think in Malaysian society, it would probably have stopped at that level. And at the end of the day, I think that the whole idea of donating organs would be, altruistic, and as long as people understand that, the person authorizing the consent would be happy to do that.
Okay. Let's talk about COVID-19. I think we saw a lot of bioethics issues at play. Governments and hospitals had to make impossible ethical decisions when it came to ventilator allocation, vaccine prioritization, and of course data and privacy. So in your area of work, Mark, in terms of pharmacy, what were some of those bioethical principles that were tested during the pandemic?
I think certainly as you've alluded to, there was a question of vaccine prioritization and who should get the vaccine first. And I think much of the Malaysian public was very much involved in those debates amidst a lot of fears about the virus, but also fears about the vaccine. Yeah. So one significant debate was also whether or not we should bring in vaccines from outside of Malaysia, which had not properly gone through the usual stringent processes that our National Pharmaceutical Regulatory Agency usually subjects new pharmaceuticals to. Should we bring them into the country and essentially bypass the usual processes in order to ensure that as many Malaysians could get vaccines as quickly as possible? And so there was quite a considerable amount of debate as to whether or not we should simply trust that some of these vaccines had been given the green light on an emergency basis by the WHO, or some authority like the FDA had signed off on it, and therefore we should just take them at their word and let it go through. And what then happened in Malaysia was that the Ministry of Health and the National Pharmaceutical Regulatory Agency actually held quite firm and did subject these vaccines coming in to a very rigorous process, a shorter process nonetheless, which then allowed them to receive temporary registration to be used in this country, but a rigorous process nonetheless. And they did receive quite a lot of criticism in the public sphere for it. People were asking questions as to why are you delaying the entry of life-saving drugs? And I think this is where you could say that the regulators were faced with this ethical dilemma where, yes, on one hand, you do want to be able to provide life-saving drugs or vaccines to the public, but at the same time, still really keep in mind that there are safety concerns to be looked at, questions around whether or not, if the FDA says that these vaccines are safe to go, does that apply to a Malaysian population? With all the differences in let's say genetics, in ethnicities, so on and so forth. The other ethical dilemma, of course, was it was a more commonplace one, whereby there were questions about whether or not, if we wanted to accelerate the distribution of vaccines, should we engage commercial parties? Should we allow corporate bodies, companies to actually participate in the selling of vaccines for profit? And certainly there were some moves within the private healthcare sector to try to offer vaccination packages to employers that was outside of the publicly managed vaccination distribution system for a fee. And so all sorts of questions about where are they getting these vaccines from? Does this then mean that if you have significant amount of resources to be able to pay these services, you would then be able to get vaccines faster? Should that be allowed in the if it means that you do have more people getting vaccinated quicker? So those were some of the very tough ethical debates that we did have in Malaysia at that time.
Yeah. And the other thing is, many felt they were arm twisted into taking the vaccine. They really didn't have much of a choice because we weren't allowing people into restaurants or to go out without being vaccinated. John, what was your take on it?
Yeah, I mean, that's a very good point. I mean, we were in Melbourne, of course, and Melbourne is, I think, considered to have the longest lockdown period of any of the big cities. I think for me, one of the very interesting tensions is the role that the government had to play in really prompting compliance with public health measures. So particularly social isolation and then uptake of vaccination. And at the time there was, of course, a lot of uncertainty about, especially initially, about how the virus would actually spread, who was most vulnerable, should we close schools? And there was, of course, as there is with any new intervention, uncertainty around the efficacy and safety of the vaccine. We knew from very early on it was extremely safe and effective, but a lot of governments who suddenly had a very strong economic and political imperative to get as many people vaccinated as possible, perhaps weren't as honest that there were still nevertheless some safety concerns with the vaccine. There are with every intervention and every vaccine, they're not unusual, and that the vaccine wasn't necessarily going to stop transmission. So I think as the pandemic progressed a little and it became clear that some governments had perhaps exaggerated the benefits and underplayed some of the risks, some members of the community took that as further evidence that you couldn't trust the government, right? It sort of put a further sort of, it gave further ammunition to those groups that you can't trust authority, you can't trust expertise. I think those of us that would consider ourselves scientifically literate would have thought, well, there's just a lot of uncertainty and governments have got to play this tricky game, and maybe for the public good that was appropriate that they exaggerated those things. At that time. But one of our colleagues, Zeb Jamrashik, is actually studying this exact tension as part of his Australian Research Council funded fellowship. How can a government convey the uncertainties associated with science to the public when doing that may undermine the public health? So very interesting tension.
Yes.
Yeah.
Did you want to add on, Adrian?
Yeah. I mean, just taking on that point, I think it really tested social cohesion and solidarity. When you're restricting the freedoms of the entire population to particularly benefit those who are most vulnerable to death and disability, people in aged care and older individuals. So those sort of restrictions and the mandates around vaccines, I think, is probably tested people's faith and trust in science and in government, which may be a challenge when the next pandemic hits, when trying to get that sort of support for social cohesion, for some people to agree to have their freedoms restricted for the benefit of vulnerable people.
Yeah. And we saw that, right? The trust in government. We saw that play out throughout the world in how willing people were to come forward and get vaccinated. I think Japan had a huge trust issue with their government based on past experience, and they didn't want to get vaccinated. And I think the other thing is also we saw how different people in the East and West took to social isolation. I think it was easy in the East because, I don't know, maybe it's our culture and being obedient and, we follow, yes, you tell me and I will do it kind of a thing. I wouldn't dare push back. Whereas if you see in the West, you saw a lot of pushback. It's my right. Don't take away my rights to move around. Who are you to tell me to isolate? So it was very interesting. Mark, from your perspective.
With regards to the vaccination?
The pandemic.
Oh, Yeah, I think,
But let's talk about ventilator allocation.
yeah, but I think before that, if Adrian mentioned, about research and how, these Declaration of Helsinki and stuff um, came out of the Second World War, I think in terms of clinical ethics, the pandemic has really been a blessing in disguise in Malaysia, because that's really, I would say, the precursor that has stimulated the growth of clinical ethics in Malaysia. Just because people realized that they weren't prepared, and they had to face all these ethical issues, such as ventilator allocation, such as vaccine allocation, and in one of our researches that we did, the other part that was out there was about then personal kind of sacrifice and burnout as a result of this moral tension. For example, as a doctor facing an unknown, I mean, most days we go to work with knowledge of diseases in our heads, and we're trying to diagnose a patient with something that we know. But then when you're faced with something that you don't know, or even if you knew the virus, you didn't know how it was transmitted, should I go to work?
Yeah.
To what extent should I put myself in the line of danger? I've taken an oath, but I also have a family. I've got young kids, or I've got elderly parents at home. So do I then go to work, come back, put these people at danger? So a lot of doctors grappled with these sorts of questions, on top of needing to manage the unknown, right? So the personal sacrifices, which then took a toll on their kind of mental health, their ability to perform because of burnout, moral distress. So all of that, right, together with the clinical decisions, really stimulated the growth of clinical ethics. So my take on the pandemic was that it was a blessing in disguise.
And also, you had to make some tough decisions as to who you were going to ventilate and who you didn't.
Yeah.
Those sort of.
Yeah.
Oh
so,
my God! It was. I
So-
don't envy. I
so we
never
were
envy the
kind of
doctors.
lucky in Malaysia, because
Yeah.
I don't think we really got to a stage where it was like in Italy, where people had to share ventilators, like in certain states in America. We had, I'd say, enough ventilators. The question was trying to coordinate everyone who needed care to the correct places. And in Malaysia, for example, we used Hospital Sungai Buloh as the main COVID center. And then we had a huge place in Serdang that was called Maebs, which then housed the less serious patients. So I think it was a matter of just coordinating the available resources, and how that actually also then played out in the interface of Ministry of Health versus public university hospitals versus private hospitals, right? And the question of then, could we really share resources? Because there may have been excess ventilators in a private hospital, but would they be used? And then I guess the other issue that we had to grapple with ventilators was then, how many ventilators do we dedicate to COVID patients, as opposed to the ventilators that we had to allocate to patients without COVID in our day-to-day kind of current clinical care anyway, right? So we still had patients who needed to go for operations and were high risk, would need a ventilator post-op. We still had patients who came in with road accidents. We still had patients who came in with heart attacks, strokes, and would have benefited. Even we don't talk about ventilators. What we saw post-pandemic was that a lot of patients with chronic diseases actually had advanced in their chronic diseases as a result of the pandemic, because their appointments were delayed, monitoring was lengthened, and patients who came in with perhaps stage 2 kidney disease and would have been monitored now came in with stage 3 or stage 4 disease. So it's that kind of resource allocation as well that had to be balanced out.
So in the future, in terms of pandemic preparedness, what do you think we should be doing? Some of the lessons we should build on for the future?
Yeah, I think, we certainly have to learn from the past in order to prepare for the future. I speak from the lens of clinical ethics. And I think we, for example, in Malaysia, have during the pandemic managed to come up with some guidance for clinicians as to how to think things through. We've put in some ethics committees now in various hospitals, which will be able to provide guidance at a much faster pace than before. Prior to COVID, we only had 2 known clinical ethics committees in 2 different hospitals in the Klang Valley, but nowhere else in the rest of Malaysia. But these ethics committees are springing out, and hopefully they'll be able to provide much quicker response. And the guidance provides, principles. But I think pandemic preparedness is much more than clinical ethics, and a lot of those decisions also are with regards to public health ethics and the public policies that you make in order to prevent patients from coming into the hospital system in the first place.
Mm.
And perhaps Mark and the rest would have input on that sphere of ethics and pandemic preparedness.
Mark?
Yeah, I think a couple of things we learned from it. Prior to the pandemic, I think our healthcare system in Malaysia was very much heavily focused on the growth of the private healthcare sector. And I think the pandemic reminded us of how important it is to actually have publicly funded universal healthcare systems that are accessible to all, that did not have to concern itself with profits and financial sustainability on a day-to-day basis. So it raises again this question of the importance of ensuring that we have these public good, these social welfare systems that are in place, which are often demonized when during the good times as being a waste of public funds, as being giving to the undeserving and the lazy and all that. I think the pandemic really reminded us that there is a need to have these systems in place. To Mark Tan's point earlier on about how we were able to sort of avoid the worst of having, let's say, insufficient ventilators and the source. A lot of that came from the fact that for many years, the Malaysian public healthcare system has been accused of having pockets of inefficiency, where you have access of this thing or access of this thing, and you would have policymakers and successive ministers, etc., say, this is an example of waste, so on and so forth. During a crisis like the pandemic, this so-called waste actually became our source of resilience. They allowed us to weather through the stresses of the pandemic. They were stretched thin, but they allowed us to still hold on together. We saw that even with the human resources in the healthcare system. Again, prior to the pandemic, for many years, it was felt that the public healthcare system in Malaysia was overstaffed. Right, you had all these doctors who entered the public healthcare system and were there for the rest of their careers. It was that a good, efficient use of human resources. When the pandemic hit, it was this so-called surplus of human resources that allowed us to actually stay resilient and weather through it, which really goes back to the point which I made at the beginning, which was when we start looking at public health and distribution of resources, and when we start to focus on efficiency, we really have to ask ourselves, is efficiency the most important thing? Or should we also start to think about what ifs, issues that crop up when we have crises like this? How do we still ensure that in the face of pressures like a pandemic crisis, we still have enough resources to provide equitable care to everyone?
John, Adrian?
Yeah, I think the marks have covered it really well.
Yeah? Okay, then I'll come to John now. Your role at the Monash Bioethics Center, your director, it involves overseeing a number of bioethics teaching programs. How do you teach bioethics?
Very good question. So we have undergraduate units in bioethics, and they're quite diverse. So some of those are introductory units that cover a range of topics related to clinical ethics, transplantation, and then we have ones that are a little bit more specialized, such as the ethics of AI, which is become quite a popular unit in level 2. So we've got our undergraduate units, we've got our master's program as well, which has a similar amount of diversity. So we have a global bioethics unit, we have a clinical ethics unit, public health units, research ethics units, and then we run the medical ethics program. So my colleagues oversee the delivery of all medical ethics training to all Monash medical students in Australia. So across that, there's a lot of diversity. We have students who are majoring in philosophy, and they are really keen to apply moral frameworks that they've learned in philosophy to clinical or healthcare settings. Yeah. So we want to make sure that we're facilitating their capacity to do that. But then we also have other students who are much more practically orientated, particularly in the master's program, where we have health professionals come in and they're like, look, I've been in this situation where I've experienced moral distress. My colleagues and I don't know how to handle this. How do we manage this? So we're catering to various types of students with different types of needs. The way I think about, or what is it that binds all that together? What is it that we're trying to facilitate? I think we can think about bioethics as attempting to build certain competencies or capacities within our students. So that might be things like sociocultural awareness, so recognizing the influence of culture and social processes in day-to-day clinical and research environments and how that might shape what is ethically appropriate or inappropriate. Moral deliberation and reasoning, so the capacity to think about a situation and think, okay, what is the core ethical tension here? And what might be an appropriate framework for navigating that tension. Yeah. So we provide them with some frameworks.
Yeah. I think based on what all of you have shared, we will not run out of content for a unit on bioethics. There's so much to talk about, but we didn't touch on ethics of AI. Who wants to take that?
Well, yeah, I mean, again, it's an emerging area. My colleague Julian Copland has developed an amazing unit, and he's really the expert on this. So we're all still trying to work out exactly how to work responsibly with the AI tools that are currently available, LLMs. As researchers, as educators. We're trying to work out how best to encourage our students to work responsibly with those tools. But then there's also the prospect of AI being incorporated into any number of uses across a number of domains, which raise a number of very challenging questions that I lack the skills to go into.
Sounds like we're in the next pandemic.
Yeah,
the unknown, how to navigate. Does anybody else want to?
Yeah, I mean, AI is such a broad, it's a tool, so it really depends where you're applying it. So it's used in autonomous weapons, in military, autonomous cars. It'll be used in the near future in surgery. So we'll have surgical robots. As well as diagnosing ultrasounds and other sort of radiography. So the issues that are raised really depends on the application. We're seeing a proliferation of large language models and chatbots that people are engaging with and using in ways that they weren't necessarily intended. So therapists, robot, AI chatbots are becoming very popular. And
oh wow!
And we're seeing.
I'm concerned about that.
Yeah. I think people's attachment to AI, to chatbots, is really significant, particularly when we have an epidemic of loneliness. And so it's a way for people to kind of make connection, which is positive, but is that connection always healthy? And we've seen a number of people develop what they've called an AI psychosis, where they think that the chatbot is alive and real, and there's been some instances of people who've died as a result of interacting with police and engaging in harmful self-harm behaviours, as harming others, and So how we kind of navigate that in terms of our interactions in day-to-day life as companions, as therapists. There's been instances where the chatbots have actually provided information that's been harmful to individuals. So, people putting in requests for wanting to know where the tallest bridge is, and then the AI chatbot providing that information, which is not what a therapist do. So they're not trained to be therapists. So these are all things that we need to learn how to navigate and to understand what is the harm and what is the risk and who is most at risk.
Yeah. So that's going to be an ongoing area.
I can speak a little bit about AI in clinical practice. So again, like Adrian said, it really depends on the context in which you use AI, and I guess the question is, what would ethical use of AI be like if doctors were to use AI to help in diagnosing and treating patients? And one of the things that that we've kind of tried to grapple with is, how would responsible use be, and whether it would be practical to require doctors to actually understand how AI works before they actually use it, because it's easy to subscribe or have a subscription to a AI tool without knowing how it actually works. And when things go well, that's all well and fine. But, as doctors, you still need to be able to troubleshoot, especially when there are problems. And so those were the kind of questions that we were trying to grapple with when we came up with, or we were drafting the guidelines at the Medical Council with regards to the ethical use of AI in clinical practice. And we concluded that at this point in time, it would be a requirement for doctors to really understand what they're using, and also then to use AI as an adjunct tool as opposed to the be-all and end-all of diagnosis, for example.
Yeah. Which is what we all should be doing, really. But it's easy.
But people need reminding, right?
Yes.
So that's why you have these guidelines there.
And I think even at the stage we're at now, there would be a lot of value in informing the public how they can use chatbots in a way that is going to enhance their access to official medical avenues. So, for example, and we've done a little bit of pilot work on this, where people have said, well, actually, I use ChatGPT or some similar LLM to say, look, I've got an appointment coming up with my GP. I want to make the best use of that 15 minutes. How do I make the best use of that 15 minutes? And it's given them some really interesting tips around, look, these are the sorts of things you should convey. And that's quite a clever use of the tool. And it also said in that response to that particular person, just let the GP know immediately that you've used this tool to structure the thing, so the GP themselves know that, okay, this interaction is partly framed by. So encouraging people to use tools in that way, I think, is really clever and interesting, but and also discouraging them from just relying on the tool as a source of medical information in itself.
Yeah. So maybe a question to John. I think increasingly then we see many instances whereby a person doesn't get to choose whether AI is used or whether AI is involved. And we see this even with our search engines, with a lot of even word processing software where AI intrudes into your work or into your thought process without asking for permission necessarily. You get AI results or AI outputs presented to you. By sort of removing this conscious choice from us, how do we navigate around that? Because then, even as a clinician, you can't choose to use AI as an adjunct because you've not made that conscious choice, and now you struggle to separate what you would have decided on your own from what AI has told you, because it's presented itself into your work.
Yeah, I mean it's a really significant tension, and you're right. I think goodness knows how many AI systems I have interacted with today already without knowing it, and goodness knows how that has informed, constrained, shaped my behavior in ways that I might not know. I mean, in an ideal world, that would be fully transparent. there'd be a little sort of notification coming up saying, remember Clippy on Microsoft Word? It would knock on the screen and say, hello, this is an AI program, just so you know. And you're right, the implication there is that there's this bit of a black box around how the AI has worked its decision-making process to inform you. So, and I don't think there's any easy answers to that aside from calls for greater transparency. Yeah.
Mark, you're going to introduce bioethics here at the School of Medicine?
That's the hope, Mira. And so we're really grateful.
I think
that,
there's a dire need we can already
yes,
see.
I think as we've heard today, there's just so many areas that we can work on in bioethics. It's really just transdisciplinary, interdisciplinary, and we're very lucky to have our colleagues at the Monash Bioethics Centre, and we'll be counting on them for support as we grow this subject in this area, not just in the School of Medicine, but as well in the School of Pharmacy. And we have other colleagues in the School of Business who work on AI ethics. And so it's really, I think, aligned with the university's kind of vision. And we really hope to be able to offer more programs, more workshops, and perhaps even eventually a master's program here at Monash.
Fantastic. Gentlemen, thank you very much for joining us today. That was John Gardner, Dr. Mark Tan, Mark Cheong, and Adrian Carter. This has been Future Conversations.
You were listening to Future Conversations, a podcast by Monash University, Malaysia. For more information, email mum.media@monash.edu.